Ash. Good evening, everybody. Thank you for joining us for the fifth IJSPT Journal Club. We have two great articles to talk about tonight. We've got a great guest host, so I'll introduce in just a moment. Just before we start, both Russ, Mike, and myself, we have a really good friend who's on tonight. We can't see him on because he's just on as a participant listening, but we have a good friend named Skip Fritz, and Skip used to work with the sports section years ago filming Con Ed. He does just Con Ed filming and does Con Ed courses. And I've worked with Skip for probably over 10 years. He's just a great old cowboy, good old boy. And he is watching tonight. So we just wanted to give a shout out to him. Skip, for the people that don't know, has been battling cancer for quite a while. He's just finished. I'm really proud of him. He's just finished his 9th treatment of 10 that he has to go. So Skip, we're thinking about you, and we hope you continue to do well. I don't know, Russ or Mike, if you want to say hi or give Skip any words of encouragement.
I was just writing on the chat room to him saying,
oh, okay.
Good job. And I saw his name on there, and I'm glad you brought it up. I know you mentioned he might be on tonight, but Skip, we hope you're doing great, and glad you joined us tonight.
Hey, Skip, Russ, good to see that you're doing okay, and we've got a lot of good memories together. Some that we can't talk about, and some we might be able to talk about.
I don't think, from what Skip has told me, yeah. I don't think you probably should talk about them.
No, there's more. Yeah, there's more of the former.
To my fellow Texan, hang in there, buddy. Keep your head up.
All right.
Call me if you need anything.
There you go. So with that, let's get started. So tonight we've got my favorite co-host, Phil Page. Phil, introduce yourself real quick again.
Hey. Thanks, Rob, everybody. Hi, how you doing? I'm Phil Page from Baton Rouge, Louisiana, associate professor at FRANU DPT and editor of IJSPT. Lifelong friends of this cohort here, so just happy to be here and looking forward to tonight.
Thanks, Phil. And our guest host tonight, our special guest host, the coolest dude ever, Russ Paine from Houston. Russ, do you want to tell everybody about yourself real quick?
I'm old. No, I really enjoy being invited with the group of guys here, and the IJSPT has been a wonderful journal, and Mike has done a great job along with Ashley at keeping the journal alive and going and well. And I think it's one of the best avenues for us to gain information, and I'm real happy to be a part of it. I've been in Houston since 1991. And I worked with the Houston Rockets for 15 years as a consultant. I worked with the Astros and worked at NASA and had good relationships with the Texans guys. But mostly I've had just a great practice in Houston, working with college, high school, old people like me with total knees, and pro athletes. So I really enjoy my job. And I really enjoy the research piece, which Lane Bailey and some of our folks head up now, and I've kind of started our postdoc program, and they've taken it along with Jackie Kay, who's really administered that. And of course, one of the guys I work with is Dr. Walter Lowe, and he and I have been together for 30 years, and we've really developed a really nice, fun working relationship. So I'm glad to be here to talk about these two articles.
I might add, Russ is a damn good golfer too.
I try. I can beat you, Mike, but you know.
That's why I said you're a damn good golfer.
There you go. There you go. That's something, isn't it?
It's something.
All right. Well, let's start with our first article tonight, guys. The first article is by Shuri. Oh, and by the way, we always send out emails to the authors of each of these articles, and so we sent out an article to Nicole Shuri, and she was busy and wasn't able to come to be on tonight with us to discuss her article. And our second article by Kim is unable. They didn't even reply back, so they're not going to be on either. So we're just going to discuss these without the authors. Hopefully that's okay. Our first article, we usually let the authors give a quick synopsis of it. I'm just going to read real quick for you what it's about. And then we can start discussion about it. It's the quadriceps strength following ACL reconstruction, normative values based on sex, graft type, and meniscal status at 3, 6, and 9 months. So the purpose was to describe postoperative recovery of quadriceps strength following ACL reconstruction related to allograft selection, meniscal status, and sex. Their methods, 125 participants, either at hamstring tendon bone, patellar tendon bone, or quadriceps tendon autografts. Checked them at postoperative 3, 6, and 9 months. Each completed an isometric quadriceps strength protocol at 90 degrees of knee flexion. They looked at average peak torque to body weight, average peak torque average peak torque to body weight, and calculated limb symmetry index for data analysis. They were placed in groups based on sex, graft type, and whether they had a meniscal procedure at the time of the ACL reconstruction. And the results were that at 3 months after ACLR, the quad peak torque was significantly higher in those with hamstring tendons compared to the quadriceps tendon. At all time points, males had significantly greater peak torque than females. The hamstring ACL limb symmetry index was significantly higher than bone, patellar tendon bone, and quad tendon. And the concomitant meniscal procedure at the time of the ACL did not significantly affect limb symmetry index, peak torque, or peak torque at any testing time period. So with that being said, do you guys have anything you want to comment on before I start going through any of my questions?
Well, since I'm the guest host, I guess I'll go first. So basically this paper is looking at, in general, if graft type matters with respect to quad strength. The one thing that stuck out with me, I'll say in just a second, but there's 3 graft types, again, hamstring graft, patellar tendon graft, and quad tendon graft, which are all pretty prevalent and popular these days. Probably more of the quad tendon, patellar tendon graft, and hamstring tendon. But the one thing that stuck out with me is something you mentioned, Rob, in your notes to us, was that this study had 125 subjects, right? And they were taken from 36 orthopedic surgeons.
Yes.
So that's a big factor with interpretation of this data. So the control factor there is not so great. Although I think it's good because it represents a community, but our data was with Dr. Lowe. We've got 700 patients that in our paper that just has gotten accepted from one surgeon. So it's, that's something to think about. We've got a city of 6.6 million people in the metropolitan area, and we have about 7 PTs that we have identified in our city to follow our protocol. So I think that makes a little bit of a difference.
Phil, Phil, talk to us about statistically, why does it skew the results, having that many surgeons and looking at a paper, looking at those, 3 different graft types, and the graft types, by the way, too, the graft types, it wasn't equal,
Right.
It wasn't equal amounts of quad tendon, hamstring tendon, or patellar tendon.
Yeah, that's right. The first thing that jumped out at me was calling these normative values is not really an accurate thing to say. And I'm gonna agree with Russ in terms of when we look at the validity of a study. Remember, we have to have internal and external validity. So the internal validity is looking at the bias inherently within this study itself, but we have to balance that with external validity. How does it apply in the real world? And so to contrast Russ a little bit, while I do agree that this 36 different surgeons and the imbalance of different grafts is an issue. It's leading us towards more of a pragmatic approach, which is saying in the real world, there are 36 surgeons doing
more
these surgeries. And but in order to get a pragmatic data to be very valid, it has to have larger numbers. We're talking big data here. And so we don't need these randomized controlled trials to look at this kind of stuff. The future of where we're going, it's going to be large patient volumes, like Russ said, with 700 from one surgeon is great, but I'd like to see 7,000 from 7 different surgeons, and kind of look at it across the board for more of a pragmatic approach.
I guess it's like I don't want to downplay anybody's skill level or all, but it's sort of like comparing the best case scenario to the real world.
Yeah,
I think that's valuable. It's like Adrian Peterson returning and getting the MVP versus a high school kid who's trying to make the team. Not a direct comparison there. The other thing that stuck out with me was that they did not measure hamstring peak torque. And then one of their kind of things that they talked about throughout this paper is that the hamstring tendon graft was much less morbid during the first 6 months of the ACL rehab protocol, and they had less dysfunction as a result of that. But at the same time, when you have a hamstring graft, and you're going to limit an athlete's ability to sprint in some cases. So it would have been nice to see the hamstring also, but I know it's a time limitation. But the other point is, what do you want to base your decision on having a graft on the problems you're going to have the first 3 months, or the most stable graft?
Yeah.
So those are kind of two things to think about also. So the bone tendon bone graft is still the gold standard, I think.
Is that what you guys used in your study you were talking about, Russ? Do you guys use primarily still?
We used
BTB?
a bone tendon bone and quad tendon graft. And in the early part of the study, we had a few allografts, but allografts are only used for, very sedentary athletes that just want to ski every now and then, that type of thing. So we've done a lot of quad tendon ACL. So now we're doing patellar tendon and quad tendon in our patient population.
Can I throw something in? This is for Phil and Russ on this, because I know you guys, all of us, even Rob on the call or on this thing, we're very fortunate that we work with really skilled surgeons in this. What role do you think, I know, Phil, you were talking about real world experience, but what role do you think the outcomes of this can be attributed in some ways to the surgeons that are doing this? And my example would be in the hip world where I am. When you use national registries or these databases, I've come to the conclusion it's garbage in, garbage out. You could have a great surgeon, and that's Russ in your case with Dr. Lowe and all this, and you'd have completely different results. Or in this particular study, Phil, that's where I'm coming in. You could have some really good surgeons, but if you had some less than good surgeons in there, all that data gets skewed. How do you factor that in?
Well, that's that pragmatic approach, right? You're going to have the bad part of it, which we have to be able to accommodate for in the real world. You do have bad, I don't want to say bad surgeons. You have
average
and good surgeons.
Yeah.
But I know in our group, when we talk, and I know, Russ, since you're the key on this, and with your studies and working with Lane, if you look at complication rates, or you look at the numbers like this study had, or we look, throw another wild card in there, but the re-tear rates that are reported in the literature, I know in talking with you, Russ, you don't see anywhere near that type of re-tear rate. You don't see anywhere near the type of complications that are generally reported in the literature. Right. And again, I have to say it's a team approach. It's what you're doing is fantastic, but I also think you're dealing with great surgeons too that understand the process.
Yeah, so our re-tear rate is less than 3%.
Which is way below.
And a lot of it has to do with, the rehab, so you can have bad surgery and good rehab and the patient's happy,
right.
So it's a team approach. But I agree with Phil that, it's a cross-sectional thing that we have to deal with. But what we have is very extremely unique, but I still think it's great to look at both situations. You can look at the best case scenario. We've got extremely talented, experienced PTs, and Dr. Lowe, and we see the other thing that makes our thing different is something that I started probably about 12 years ago, is our post-op recheck clinic. We start that at 8 weeks post-op, and we do it every 4 weeks. So if a patient is not doing well, we will pull them from whatever rehab situation they're in and make them come to the med center, where we are, and get them back on track. So I think that's a huge factor. And then another topic for discussion is functional testing, which we also do. And we have like 7 functional tests that have to be performed at 90% or greater, and to allow them to return to play. So, I think it's good to look at the best case scenario. And this is not something that happened overnight either. It's an evolution. We have gotten better and better and better. Initially, Dr. Andrews and Kevin Wilk started this, and even back in Columbus, Georgia. So it's not a new thing, but we've taken what they've done. You got to have space to do that, and you have to have staffing to do that. But anybody can do a single leg hop, though.
Yeah. Well, you know what? It's interesting you brought up that re-tear rate, because Russ, I'm going to see if you see the same thing, because we don't do 7 functional tests, but we do the jump test, we do the hop test. So single leg, we do double leg, and then we do George's left test. And invariably what we see is that the people that typically end up re-tearing, and we don't have that many, all I'm seeing really now, but my majority of what I'm seeing now are quad tendons. And the people that re-tear are almost always the people that do great on the strength test and the functional test. But I think that's because they're going back to higher level activities than the people that aren't doing as good. So, just because someone does, someone can do great on all of our tests and re-tear, even though you think they're, physically, objectively, they're doing unbelievable. They're like fantastic. They're like your best patients. They're the ones that will re-tear sometimes.
Now, the other thing that Dr. Lowe is looking at over the past couple of years is the tibial slope. And so you can have someone that looks perfect, but if they have more than 12 degrees tibial slope,
posterior tibial slope, right?
Posterior tibial slope.
Yeah.
So basically the tibia's, the femur sliding backwards and the tibia is sliding forward because of the orientation of the tibial slope. If you combine that with not great quad and not ability to land in a deeper knee flex position, he's going to have a really tough talk with the parents and the kid to have an osteotomy performed. And so that's something that we've done, especially in revision cases that didn't get the tibial slope looked at. So that's one factor that Dr. Lowe's put into our solution, kind of parameters that I think is something to look at.
Yeah,
we have a different, he has a different surgeon that does the osteotomy. So they have a team approach to fix the ACL with someone that has more than 12 degrees slope.
Yeah, I'll be interested to see what that shows, because that's a great idea. And there's a lot of time when we go to like the AOSSM meeting, the OSET meeting, there's people talking about the tibial slope. So it could be a big factor that we just really didn't know.
We haven't figured it out yet.
Understand.
Someone looks perfect and they pass the functional test. Why is it happening? So that might be one factor.
It could be. So tell me what.
Go ahead.
Sorry. No, go ahead.
The other thing that was interesting in this article is they looked in pretty good detail about the limb symmetry index versus what I'm calling the peak torque to body weight ratio. They call it the Newton per kilogram ratio, but in the sixth grade, when I was in the sixth grade, we were supposed to convert to the metric system.
Yeah, we didn't ever do it either.
And everybody was getting ready for it, and it hadn't happened yet. So I'm going to talk a little bit about that. But in this study, they actually quote. Because they believe that the peak torque to body weight ratio in the study was more indicative of, a little bit better data compared to the limb symmetry index, because they believe that, during the first few weeks, your quad is weak and the limb symmetry index is not as prevalent as a peak torque to body weight ratio. But they also quoted a study by Chang, who actually is an author on the next study that we're going to look at from Seoul, South Korea. And he showed that when you have an ACL tear, you have inhibition and weakness of the normal side. So this article states in support of that your limb symmetry index is going to be off because your normal side gets weaker. But I don't quite agree with that, because what we see is as the patient progresses, their normal side gets stronger. That's what we see. Maybe the first 8 weeks.
Even early, Russ, or are you saying it
like not early, but later on, the limb symmetry index is not as, maybe someone progresses much better in the rehab process, but the limb symmetry index is not changing because the normal side is getting stronger.
Yeah. If it does,
the involved side can't catch up to it because they're stronger than they've ever been once they complete our rehab process.
Yeah.
I think the peak torque to body weight ratio is really important to look at.
I think it is too. What are you wanting them to be at with their peak torque to body weight ratio? Are you testing it, or what? Are you testing it at 60?
Peak torque to body weight ratio ultimately should be what they call 3 Newton meters per kilogram. Okay.
So what does that mean
anything to anybody? So
that's too
Jesus, Russ is down there at NASA giving us all this stuff.
I know.
Can you talk about the rest of us in the South?
Yeah.
So basically, we did a study in 2015 published in IJSPT on healthy high school football players. And our peak torque to body weight ratio at 60 degrees per second was like 138 for skilled kids. at about 115 for non-skilled kids.
You're saying 100%,
You should
115%
be able
of
to
their
kick
body
out
weight
your body weight. So if
Yeah,
you
yeah,
weigh
yeah.
150 pounds, you should be able to kick out 150 pounds of torque.
at 60 degrees per second. Yes,
Yeah.
I agree. I agree with that 100%.
So that's 100%. So if you look at the, if you convert that to nanometers and kilograms, if you have.
There he goes again.
There he goes again.
100%.
We're back to the Artemis
Yeah.
project.
That's right.
Holy
If
crap.
you have 100% as your criteria and you have 150 pounds of torque, you multiply that by 1.34 and you get 201 Newton meters. And if you weigh 150 pounds, that's 68 kilograms. So if you divide that, you get 2.96 Newton meters per kilogram, and they said 3.
So does that affect the distance to the moon for how many days?
Well, I'm working on that.
I know you are.
I don't think I have
Anyway.
a job here anymore. No more stats for me. I think
Yeah,
Russ
no,
take
no,
over
Russ just took
that.
over your job. Yeah.
Good. Go ahead, Bill.
Russ,
Get
if
your
you're on
slide
next
rule
month,
out.
Russ, you're on in December. We're kicking Phil's ass off.
I don't
okay?
know statistics.
Wait, I do have one statistical question real quick for you guys, actually. One of the things I noticed, they talk about the tests that they ran, which seemed appropriate. They just didn't specify which exact data sets they used, which specific tests for. And they ran a power analysis, which seemed to be okay. But as I was looking at it, it's relevant to the discussion you guys were just having. And we look at, how I feel about p-values and significant differences. Was there a clinical benefit to any of these differences? Did you guys see that these differences meant something clinically?
Well, it was low to moderate, right? So that the maximum correlation was low to moderate. It was like 0.3.
Wait, that not in this paper. That there wasn't a correlation in this paper, was there?
Okay.
Are you thinking of the other?
The other paper will.
Oh, okay, I'm sorry.
Yeah. No, like the limb symmetry index, between the 60%, 76%, or even the Newton meters per kilogram differences that you would see between males and females.
Well, basically, I mean, the hamstring tendon population is going to get their strength back quicker.
Get
So
their
their,
quad strength back quicker. Yeah.
yeah, and their limb symmetry index is going to be better. So they're going to have a much easier time with the rehab process.
Out of the
clinically.
gate. Yeah. Out of the
So-
gate, it's going to be better.
So the
They
conclusion of this paper was that they wanted you to know that patellar tendon and quad tendon patients are going to have a tougher time. So you need to focus more on their quad strength than, the hamstring tendon patient clinically is going to do better.
Doesn't that make sense in the first
Well,
place?
Yeah,
that's
but I
common
mean,
sense in it. Yeah.
I'm not going to disregard anybody that has a quad deficit. I don't care if you fell down the stairs, I'm still going to work on your quad. Yeah.
Hey, guys, we had a couple of questions here. One of our good friends and editorial board members, Barry Schaefer, just wanted to point out and get the comment, since I brought up the thing about talking about the MDs and the quality of our surgeons. He also said, brought up that, there was 125 patients, but there was, I believe there was a considerable number of PTs, and quite possibly could have been different protocols involved in this. So we might have to look at, if there's a problem, we might have to look at ourselves a little bit within our own profession with the quality of what we do. And as Russ said, he's already doing that with his clinics, because I'm sure the way that works, as you said, Russ, if somebody's not hitting those milestones you're looking at that 8 week and every 4 weeks after, you're bringing them back in-house.
Right.
Good. So he wanted to bring that up. And we also had another question here. And this, I hate to almost bring it up because we're going back to NASA with Russ, but
Let's just leave that one.
yeah, are you
Alberto,
able to?
Alberto, why did you have to ask this
had to cut-
question?
had to-
You're like
Alberto had
taking
to
us
bring it.
back. You're
Take
taking
us back to this. Could you extrapolate the 3.0 Newton meters per kilogram to isometric? Because that was coming off of your isokinetic testing. And Phil, you might be able to jump on there because you've got a lot of published on isometric work too. But could you extrapolate it to isometric testing?
Yeah, well, you'd just be Newtons. Newton meters is going to be
Right.
A torque. So if you just did an isometric 10, you would just basically have Newtons.
Would our numbers be comparable?
No, you'd have to, like Russ was doing the math with the conversion factors and all that stuff. I think it might be a little bit different. I'd have to do the math.
He's probably got a slide rule in front of him doing something.
He's checking it. He's checking it right
He's
now.
checking it right
He's
now.
going to get back with us in just like 5 minutes and tell
Yeah.
us.
Yeah.
I agree with Phil on that one.
Yeah.
So Russ, let me ask you this. They talked about doing the changes strength based on graft type, and they even go as far as to say that we should use different time frames during rehab and return to sport based on whether someone has a bone patellar tendon bone, hamstring, or so. I mean, these are all autografts; they're not allografts, which is a whole different. That's a whole different discussion. To be honest, I think with allografts. But do you feel like we need different time frames for everything we're doing based on autograft graft types?
Not really. I mean, the thing that alters our time frame is not the hamstring tendon or quad tendon or patellar tendon graft, but if they have a concomitant injury, such as a root repair or articular cartilage,
Cartilage
lesion,
damage,
that type of thing. But we don't really do hamstring grafts. So we treat our quad tendon and patellar tendon grafts exactly the same.
Is your quad tendon, do they take a piece of bone
No.
off the patella, or so it's all soft tissue?
Yeah, it's all soft tissue.
Okay. And so you may slow that one down just a little, but I mean, you're not slowing it down that much, right?
Yeah, I mean, that's the new thing now is really what they call fertilization of the tunnels. And that's kind of a new thing that they're trying to improve the capability of the soft tissue graft to incorporate a little bit better. And that's one of the problems with a hamstring tendon graft. Whereas the bone graft at 6 to 7 weeks post-op, you've got Sharpie's fibers that are thrown all the way through there, and it's like solid.
It's solid quick.
Yeah, so
relatively quick.
Yeah.
Good. So do you guys, so you said you rarely use allografts, right? In younger athletic populations.
Yeah,
I mean,
we
it's
do
just
not do that. Yeah.
Yeah. Mostly. We've got a couple doctors here that do, but I don't understand why. I mean, I still don't understand why. It just doesn't make sense to me. And it doesn't to you. So that's good to know we're thinking the same.
Yeah, but I mean, you can have someone that has, we recently had, because Dr. Lowe's doing several ACL repairs lately where it pulls off the bone and the actual ligament is intact. And I've had two ladies that, similar age, middle-aged ladies, and they've had motion loss complications, no quad. So it doesn't necessarily, in my hands, determine that you're going to have a great time if you just have a certain type of graft. Someone can become inhibited and get stiff with any type of knee surgery, almost, patellar tendon graft. And I tell you what, with our quad tendon grafts, they struggle the first 2 months. And all our PTs in Houston that deal with the quad tendon grafts, and then they do fine. I think they do better with the loading stages of the ACL rehab with regard to lack of patellar tendon pain and that type of thing. But those first 2 months are pretty brutal for them.
Yeah. So Phil, I'm gonna just like give you a nerd alert here for just a minute, because when I was reading this article, and you tell me if I'm crazy, you and Mike both, I guess, and Russ, you can tell me too, but if you really look at these articles, and anytime we have a research article, for some reason, I want to see a hypothesis at the end of the introduction. And I think both of these papers, neither one of them, I think, really even had a hypothesis. Is that just, am I crazy to want that? Or am I crazy or am I okay?
Well, the first thing you always want is a purpose statement.
They did have purpose.
Clearly stated in the abstract. Technically speaking, if you're going to do statistical testing, a significance test, you have to have a hypothesis. That's just the rule of doing. If you're doing p-values, you have to have a hypothesis, because that's what you're doing with p-value testing, is you're testing the null hypothesis no matter what you're doing. Whether
so what you're saying is I'm not crazy.
No, you're not crazy, but
well, it's still a vote.
No, let's not vote. Let's not vote.
But it's not implicitly stated here, but it should be. Yes. Right. If you're doing any kind of, it's null hypothesis testing. So you should have a stated hypothesis.
Good. Thank you. Thank you for confirming my bias there.
Yes, no problem.
All right. One more question here. I thought this was a little strange too, because their warm up for the isometric testing, their warm up for the isometric strength test was actually doing an isokinetic test through a self-selected range of motion. Wouldn't you want to do the warm-up isometrically if you're testing them isometrically?
I don't think it matters that much. I
It
think, you know, I think you do need to do a warm up, and that's one of the problems that Dr. Lowe has with doing some testing on our patellar tendon graft patients, and we do isometric tests at 8 weeks post-op, and they go upstairs and they're complaining about their pain after the test, you know, because they haven't done.
So what do you guys do for your warm up?
Well, they, you know, I don't do much, you know.
So do they do like a spike or anything
Yeah,
to warm
just
up?
they do a little bit of manual warm-ups with isometric, just like you said. But I
Okay,
think
well,
it's
so
probably, I think it's not a bad idea to do just a little active range of motion with some resistance to get it ready for the big load. You know,
yeah.
because that's a maximum effort that they're trying to do, maximum voluntary contraction. You know,
Yeah, I guess I was just thinking if that's the specific mode that I'm testing, that would be the way I would. I mean, if you're, let's say you were doing an isokinetic test, you wouldn't do 4 warm-up isometric tests for your warm-up. You wouldn't do
Yeah.
a different method for your warm-up. So why would you do it if you're doing an isometric test?
Well, nobody uses isokinetics in rehab now except me. You know, my patients are ready to go when we do this test. Because I do a pyramid 180, 210, 240, 270, 300 and back down. And it's one of the best things you can do for an ACL rehab, you know, patient. The
Get some
high
strength
speed
back,
workout
yeah.
is fantastic, you know.
Yeah. Russ, tell me this. When you, since you're doing, you're seeing both bone patellar tendon bone and quadriceps tendon, both, they state in the introduction that the quad tendon produces significantly less quadricep weakness compared to the bone patellar tendon bone. Are you seeing that early?
No.
Because I'm not.
No,
I think it maybe sometimes it's worse.
they are worse. I mean, some of
yeah.
them takes sometimes 2 weeks before they can do a straight leg raise.
Yeah. Yeah.
You know, and we had a pro player, you know, this past week that came into town, and he was able to do a straight leg raise in recovery after a patellar tendon graft.
Yeah.
Quad tendon grafts, I'm telling you, they tend to have a little more difficulty with quad, you know, activation.
That's what I thought too. So they stated in the introduction that quad tendon repairs produce, or reconstruction, produce significantly less quadricep weakness compared to bone patellar tendon bone. However, what they say in their study, when you look at the study at each time frame, the quadricep strength was less than the bone patellar tendon bone strength. So it almost, that to me almost contradicts.
It's a little confusing because they look at peak torque to body weight ratio for one set of, you know, circumstances, then they look at peak torque or the limb symmetry index for the other.
Yeah.
You know, so you got to read the paper 2 or 3 times to kind of get what they're getting at, you know.
Yeah. It was a little confusing. Phil, did you have more you wanted to?
No, but I think George had a question. Mike, is that right?
Yeah, well, we got George Davies with us again.
The general.
Tonight, so
The
general's
general.
on.
Awesome.
He's keeping us honest. That's for sure. He always checks in with us. But Russ, he put out there, he said, besides doing the isometric test versus dynamic test, is it really ecologically valid to test at a 90-degree angle? I'm assuming again that's your isometric.
What does that mean?
Well,
real world. Is it real world to test?
Okay. Yeah, I think you can do that with a handheld dynamometer, you know, and not have to have an isokinetic. But at 90 degrees, you're having the most amount of torque produced at 90 degrees in the open chain situation, you know, open chain knee extension. So at 90 degrees, you've got the most efficient position for your quad. And near full extension, you know, you have more EMG activity in open chain, but at 90 degrees, you're going to produce the most amount of torque. So we actually, you know, have a setup in our clinic where we do handheld dynamometer at 90 degrees with an isometric, you know, setup.
there's another question, a couple on there. 2 of them. One, I guess I'll do the easy one that Suzanne asked us. Could you repeat that pyramid workout that you do? Give a little detail on that.
Sure. So the pyramid workout, we would do that at about somewhere around the time that they're allowed to run. So it's, you know, if you do a high-speed workout, it's probably, if you think about it, as you go into knee extension and you're doing a high-speed workout, your hamstring is firing to pull the tibia or to stop the acceleration, to start the hamstring curl. So I think that it's pretty safe. So we do 10 reps at 180. We do 15 at 210. We do 15 at 240. We'll go up to 20 at 270. And then we do 30 reps at 300. And then we go back down and do the same thing. So the last set, the 180 speeds are each done at 10 reps. And those last 10 reps on the 180 are killers.
They're killers.
And I worked on an athlete at U of H, Leroy Burrell. I don't know if you guys remember him. He was a sprinter. And he had the world record at one time. And he had an old ACL. And he wanted to come in to do some quad strengthening before the meet. And I got him on there, and his thighs are like this to start with. And so we did a workout, and he got off, and he thought that he had a blood vessel burst or something. So what's wrong? He got off, and his quad was this big. And then 6 months later, he set the world record.
That's crazy.
So it's great because you can do quad and hamstring strengthening at the same time. And I think it's a neuromuscular benefit also. To do a high-speed workout, you've got to really switch your switches on and off quickly. And I think a lot of people have gotten away from that, but I think it's still a good tool. If you got one, dust it off and plug it in and try it out.
I agree with that. And we had one other question from Alberto again. What were the 7 milestone tests you performed?
Okay, so I've got that right here. I've got a prop where I can show you what we do. This is
awesome.
our functional test printout that we give to Dr. Lowe. And I'll just read off the test for you. We do the IPDC test, we do the Marks total score, and the RCI, those 3 tests. One's a psychological test, and one just patient's evaluation of their certain functional level. We do range of motion testing. We do a single leg squat. We do the less landing test, where you jump off and land on one leg, and that's pretty simple. That's just a gross test. We do a figure of 8 40-yard obstacle course, and I published that in the 2015 IJSPT on the healthy kids, high school kids, and we found that 9.5 seconds was a normal number for a really fit high school football player. So that's our criteria for the figure of 8 40 yards. So you got 10 yards and you go around it twice to equal 40 yards. And then we do a 5-10-5 agility test. We do a single leg hop for distance. We do a crossover hop for distance. We do a 6-meter timed hop, and then we do a triple hop for distance. So that's 1, 2, 3, 4, 5, 6, 7, and then the single leg squat. But that's done at probably the 6-month mark. So probably for the first 4 months or so, we'll just do a single leg squat. And we'll talk about, more about that in our next article.
Hey, Voight, the general's active on the chat tonight.
So,
You got another?
Velocity spectrum.
Yes, Russ, that's the Velocity
Davies.
Spectrum Rehab Program.
yeah,
Back
I
in
need
the,
to give credit
40
for George
years
Davies
ago
for
from
that.
Davies.
I got the book still, so I got a
Hey, I
signed
do
copy,
too.
by the way.
I could show you. It's
Yeah.
just right behind me. It's
Yeah.
under the globes here in my room.
Under the
And
globes.
if you've ever looked at George Davies' name, he needs about 3 paragraphs for all the
Initials.
initials behind it. So
He's done
we
a
love
lot.
you, George.
He's done a lot.
He's done a lot, and we appreciate his input.
Yeah.
All right. Do you want to answer these questions, guys, or you want to move to the next?
Let's go to the next one real
Go to
quick.
the next one. Sorry.
We might come back to
James
him.
and Thomas, if we
Yeah.
have time, we'll come back. So we'll keep those up so we can look at them. The next study is by Kim et al. Correlation between Y balance test and balance, functional performance, and outcome measures in patients following ACL reconstruction. Their purpose was to examine the relationship between Y balance test scores and measures of knee joint laxity, static balance, knee flexion and extensor torque, and strength ratios and functional performance tests. They had 59 patients who underwent ACL reconstruction using hamstring autographs. They were retrospectively analyzed. They found, there were 46 men, 13 women. Mean age was 29.6 years and 12.4 months, respectively. KT 2000 arthrometer measures, Biodex balance system scores, and ham quad ratio measurements were not significantly correlated with the Y-balance test scores. All Y-balance test scores except the anterior score correlated with isokinetic extensor and flexor torques. All Y-balance test scores had significant weak to moderate correlations with single leg hop test and single leg vertical jump test scores. Y-balance anterior, Y-balance posterior medial. Well, that's just the the rest of that is essentially telling you what the correlations were. So, all right, let's have at it. Who wants to go first?
I'll go. I want to go. Can I
Okay.
go?
You go, Phil. You're up.
So the question that I took away from this study was somewhat interesting in that you're doing a balance test, and the surprising thing was this lack of correlation with a static balance.
Yes.
But we know Y balance is dynamic. It involves movement. It's totally different than static balance. It doesn't really shock me that all these static measurements were not related to a dynamic balance test.
So really the dynamic balance test may not, that was what question that I had on my list was it may not be really a balance test.
It's not, it's more of a functional kind of thing.
It's
Yeah.
a functional balance test.
Yeah.
Because you do have to have some balance to do it.
Yes. But the problem that I have with this from a statistical standpoint is pretty big, in that they ended up doing, I think, 32 measurements or relationships, correlations. And there's we've heard of regression to the mean, or at some point, something's going to be significant. Even in 100 times that we do a test, 5 of them with a 0.05 confidence level, 5 of them are going to be significant. So when we're doing 32 tests, we have to accommodate for that statistically, and we should have done a Bonferroni correction for
I love the Bonferroni.
Loving the Bonferroni to take into account that over doing 32, it's inevitable that something's going to be significant just by chance, if you will.
I just like saying Bonferroni. Don't you, Russ?
Yeah.
Yeah. What is that, Phil?
It's the name of the test that we, or the correction that we do when we have multiple comparisons.
Multiple tests,
within
yeah.
One test, one study from individuals, just in general, 32 times, at least one of them by random chance is going to be significant.
Got you.
So your significance level changes based on the number of tests when you use the Bonferroni.
You would divide it by the number of tests that you're doing. So it dramatically drops down your alpha value or your significant p value. The other thing I wanted to point out with this is an important distinction for everyone listening when you look at correlation studies, right? So you need to know the difference between a correlation and a significant p-value. A correlation, or an R, really, a Pearson's R value is just the strength of the relationship between only 2 continuous variables. And we know it could be +1 is a perfect linear positive correlation, or it could be a negative correlation, or it could be 0, it could be flat, right? But what you want to be careful of is when you see the term significance, and we look at a significant correlation, doesn't mean that it's a strong correlation.
Exactly. I had that drilled into me when I tried to publish this, or it got published, but the editor was just like hammering that at me that just because.
So most of these correlations
strong.
in this paper are low to moderate, right?
Yeah,
Yes.
exactly. And so what I wanted to point out in this paper,
I had a brain fart on the others.
the Pearson's R is like an effect size that you would see. It's the strength of the relationship. So 1 is extremely strong, 0 is none. But if you look at the numbers that they have when they do have significance, like Russ was saying, anywhere from 0.2 to 0.3 or 0.4 to 0.5, moderate at best, yet it was significant. What I want people to understand, that it's still moderate. What the significance means is that we're pretty confident that that's the actual value that we would see in the population based on this sample if we repeated the test 100 times. That's what statistical significance means. It doesn't mean that 0.45 is a strong, great correlation. It just means we're very confident at a 0.001 value that we're pretty confident that's the true value of the population. So that's the main things I wanted to point out with these types of correlation studies.
Hey, Phil, that was a hell of an answer. With that,
It was really good.
no, given the fact that to the other guys, I called Phil earlier this afternoon. Actually, it was before noon. I called Phil with a statistical question. He happened to answer the phone, but he was sitting in a Cajun pub doing shots.
What?
That was before lunch. That was a hell of an answer, Phil.
It looks pretty good right
That was
now.
a good
Looks pretty
comeback.
good.
That's a
Hey,
good
I'm not
comeback.
lying, Phil. You were in a pub.
Phil's just grinning. He's not
Yes,
saying
he
a
is.
word.
Hey, Russ,
Yeah.
you don't have to apologize for screwing up and confusing the two studies, man. Hey, I love your enthusiasm. You were just excited. You were ready to go, and you just jumped to the
I
next
tell
study.
you
You
what,
don't need to apologize.
I tell you
for
what
being
screwed
excited
me
about
up
it.
is I looked at you with those headphones on, and it just my brain just like kind of blitzed for a minute.
It wasn't the beard, Russ. It wasn't the big
That's a bit-
The
Should be the
combo,
beard-
it
the
kind of
combo,
matches the
yeah.
silver and silver,
Yeah.
silver.
He's looking good.
Getting good, man. It's getting good.
Oh, man.
I will tell you one thing that really I loved about this study, and I mentioned this in my notes that I sent to you guys, is that the introduction in this thing was fantastic. It was like brief, concise.
Yeah, it was good.
It was really good. We don't always see that. I mean, it was tight, it was clean, it was good. Sometimes, they're like 5-page introduction, and about half of it you don't really need. This was just like clean.
One of the things that caught my attention with this was the Y balance test anterior reach had no correlation to the quad and hamstring torques. And so, but the posterior medial and posterior lateral where you reach behind, they had a moderate correlation to the torque. So that to me didn't make too much sense.
I agree.
Because, and I looked up the article, an article to refute that by Myers and IGSPT in 2018, and they showed the opposite. They showed that as you reach forward and doing a single leg squat, like a pistol squat in front, then your quad activity is greater. But one point they made that I thought was really good is that possibly the reason why maybe they thought that you had less quad activity with the anterior reach is a lack of dorsiflexion. So if your calf is tight and you can't go more forward with a single leg pistol squat, then you can't go deeper in the knee flexion. And
You can't generate more. Yeah.
one of my PTs I work with, Chris Galena, had a comment and said, well, we should always do a heel lift when we do a single leg squat, single leg reach, because it will limit your ability to reach forward if you have a lack of dorsiflexion.
Correct.
Yeah.
Good point.
The other thing I comment about this is that Dr. Lowe does makes all of our patients do a single leg squat in front of him in the treatment room. And I think that's a good thing to do. It's a quick and dirty assessment, but he'll start that at 8 weeks post-op, and you can look and see side to side. It's not objective, but you can see if someone's got, their hip is all over the place, or their quads, not good enough to let them go deeper. So that's just a good quick and dirty test to do on your patients.
Yeah, there's a lot of compensations. There are a lot of ways that people can squat, and you can deem a lot of stuff by looking at it. We use it a lot too. Yeah,
Right.
It's very good.
And the Y balance test also showed, in our study, it showed no correlation to return to sports. Even though this one had a moderate correlation to quad peak torque and the single leg hop and the vertical hop. In our clinical setting, we use the functional reach assessment to see if they're ready to run on the treadmill or early phases of rehab. So the thing that looked, the thing in our study, when we get to the end stage of rehab and the ability to return to play or not return to play, the factors that were most important in our functional testing were quadricep strength, and the p-value for that was 0.003. So the patients that were unable to return to sports had an average of 77.2% of normal versus 92% of those that were able to return to sports. And they also stated that 65% of their patients were returned to sport in the other study that we looked at, a few minutes ago, but our return to sport numbers are 88%. You know, so
Good
that's
night.
another thing. Another interesting thing was the triple hop for distance in our functional test was 0.026. So it is pretty highly significant. But the triple crossover hop was 0.872. So there's almost no difference between normal and involved in the crossover hop test versus the triple hop for distance. So why do you think there's such a difference there? You guys have any ideas? I got my own thoughts. I'm like Kevin Wilk. I already know the answer, but I'm trying to stump you.
Yeah, I don't know. Just give us yours. Tell us what
So,
you think.
you know, the single leg hop was highly correlated, or it had a significant value of 0.04. So a triple hop for distance is basically 3 single leg hops.
Mhm.
Okay, so that's easier for you to do on the normal side. A crossover hop for not great athletic people is more difficult to learn. So probably the normal side values on the crossover hop, triple hop, or less, so that makes it more even to the involved side.
You think it's less because it's more of a novel.
It's a more difficult test to
Yeah,
perform.
and they
on the
don't do it.
normal
They may hop single on their forward leg some,
Yeah.
but they don't do a crossover hop typically. So it's
Yeah.
unique.
But the other point of discussion is, all these functional tests that we do don't always correlate to quad strength. And we've had numerous discussions about this. So what do you guys think we're missing? Why can someone with a 30% quad deficit pass 90% or greater on all these functional tests?
Because they use other stuff. I mean, they're using other,
They're compensating.
Yeah.
So we're missing something, right?
Well, that's a good segue because it wasn't in the study, but I wanted, Russ, since we had you on tonight, and you're the one that sort of enlightened me in this. You want to comment a little bit and there were a couple questions about functional testing. You want to comment a little bit about what you're doing on your backward hop for this? Yeah.
So a good question for people to think about is, what is the function of your quadriceps during sports? And there's nothing written about that in the performance literature. So if you think about it, your quadriceps is used, I think, primarily for deceleration. So Michael Jordan was our era superstar. So Michael Jordan would beat everybody because he would stop and do a step back. And he was so fast at putting on the brakes that he could come back and shoot that 3-pointer or shoot a jump shot. But that was all pretty much quadriceps. So I was at the golf course one day when my kid was young, and I was running downhill. I got really bad knees, and I realized how hard it was for me to run downhill because it was all quad, and it increased my patellofemoral compression force and my arthritic knee. And I'm like, you know what? This is what we're missing. So Lane and I started looking at different ways, Lane Bay and I looking at different ways to try to get deceleration testing into our protocol. So if you look at all of our functional tests, they're all acceleration tests. You jump and you land. You jump and you land. So you can get away with having almost no quad. So what we're doing is doing a backward single leg hop. So you jump forward, you load your quad, and you jump backward as far as you can. So you measure the distance from your heel to your toe. I don't care where you jump, it's just the distance that you jump backwards. So we've used our little M-trigger device to measure.
So hang on a second. Hang on, Russ. So
Yeah.
you're having them go forward first. That's your
Right.
concentric
Single leg.
your single leg. And then when they land, then they have to explode and go
Immediately.
backwards.
Immediately jump backwards.
And you're measuring it from where they landed on the forward or from the start position?
We land where they land.
But I mean,
From the forward.
is the reference to the
forward.
start position where they began? So
No, that has nothing to do with anything. So once they land, we're measuring the distance from their heel landing position to the toe landing position
Gotcha.
on the
And the
backwards.
backwards. Yeah.
perfect. Got it.
So we've done just some preliminary looks at this, and we put the M trigger on where we figured out a way that you can use the biofeedback to do a 10-second exercise session. And so you start the biofeedback, you jump forward and back, and then you just stop it and you look at the peak EMG activity of your quad. And we're showing that it's a little bit more with a backward single leg hop. So hopefully that'll be something that'll fill that void in for people that have a quad deficit that are passing all these functional tests. And I think we're just missing something on the functional test to fill in the blanks, because without question, every single study shows that the number one reason that people are unhappy with their knee or unable to return to play is quad deficit. Every single study shows that's the most significant finding.
I think there's one more factor we're seeing at Tulane with our athletes is it's a lack. We do everything in the sagittal plane, and a lot of the testing that we do is in the sagittal plane and acceleration. But what we're missing is the frontal plane. And so what we're seeing is when we do our biomechanical analyses is that these athletes tend to keep the injured limb closer to the midline through the stance phase because they don't want to contract to the hip abductors to stabilize it because it's weak. So biomechanically, they're keeping that leg underneath their center of gravity. And what we're trying to do is now work more lateral movements into it as soon as we can.
There's no question we got to worry about the hip a lot more than we do too. And we put in 3 hip exercises in our ACL rehab protocol. But the second, I think what the second most important function of the quad is during landing. So if you don't have quadriceps function, what do? You land in a little bit more extension, right? So you land with a stiff knee. So you land at maybe 20 degrees of knee flexion. So your hamstring vector is a vertical vector now. So we'd like for them to have, if you have really good quad control, you can land in deeper knee flexion. So now your hamstrings have a better chance to pull the tibia posterior. But if you land with your knee in a stiff position and you have a posterior tibial slope, then you're really got some issues. So, so when you do, it's not just strength, but it's teaching them how to land in a deeper knee flexion position.
Russ, you got a question here from Zach Thomas. For the backward hop test, are you standardizing how far forward they have to jump initially?
Absolutely not. I don't really care how far forward they go. It's just, as far as they feel comfortable, because we want them to get all of the power going backwards. So, it's just kind of a new test for us. So we'll have more detailed data on validation of the test compared to the single leg hop. Single leg hop's a great test.
Russ, how far are they tending to jump backwards in terms of distance? I'm just curious.
It varies with the individual. It's
as I'm thinking about a good study would be force plate study.
Yeah.
I would set up my force plates. I have 2 of them. They'd have to jump on one and then hopefully have the next one behind them far enough away so that it'll actually hit it. And we could look at some really good reactions in 3 planes.
Right.
That would be a really cool study to do.
And then you combine that with our EMG, the M trigger, which now we're starting to use it for more active things since one of our employees kind of figured out a way to use it, actively. So that's kind of cool.
No, I think that's one, you guys know this from other discussions we had with this, but I actually think Russ is spot on with that. I've used this in other slides. I know, Phil, you've seen it when I've talked, but I'm sort of calling this thing a deceleration index, where you have deceleration over acceleration. And the reality of it is, it's something Dr. Andrews said years ago with the throwing shoulder, that, you're not going to really, an athlete typically is not going to accelerate their arm faster than they can decelerate the arm. If they do, we're setting them up for injury. Well, why wouldn't that be true in the lower quarter? I've been looking at it. And I think there's something there, and I think you're onto it, Russ, that I'm looking at athletes that we've seen and people we're testing, that in this day and age, in the strength and conditioning side of things, these athletes are getting bigger, faster, stronger, and they're able to generate tremendous amount of power in a linear direction, as Phil said, but in a concentric manner, because that's how they're training. They're doing squats and things like that. They're not really doing like an overload eccentric type of deceleration training. And what we're finding out is that when you test for both sides, or you look at it in function, some of these people have incredible acceleration values and they have horrible deceleration values. And we have a longitudinal study going right now looking at it with an SEC school, pulling catapult data and looking at, and there's definitely something there with the data we have. The kind of interesting thing is we can go back retrospectively, and if a guy gets injured, pull their catapult data from the week before in game day data. So I can see what your ratios were before you got injured. and then look at some of the others. So I think this back, I'd like to figure out a way, that's why I brought it up tonight, to work this backward hop in there somehow, because the reality of it is not everybody's going to have these multi-million-dollar telemetry systems to measure everything on these athletes when they leave the locker room. But
Right.
there's got to be a way, what you're doing, to bring it down and dirty in the clinic and get that side of it. And I think you're right. That's a missing piece.
I think to Phil's point, moving laterally is a deficit with a lot of players,
Right.
but in order to start to move laterally, you have to decelerate.
Yeah.
To
Yeah.
stop
I'll
and
tell you
then-
something funny, Russ, on that. I'll tell you guys something real funny on this. You get a charge out of it. The team sent me all this data to look at, and there's like 1 million data points when it comes in. And I was looking at a couple of their skilled players, and I was trying to figure out this acceleration deceleration ratio. And I was looking at the data, and all of a sudden it dawned on me. I said, I said, God, this guy can stop on a dime. This guy's got deceleration rates that are like through the roof that I've never seen before. And he has high acceleration too. And then it kind of dawned on me. He didn't have good deceleration because it wasn't all the time. It was only some of the time. This guy was getting crushed over the middle by a linebacker. He was hitting a brick wall. He wasn't decelerating, but somebody was decelerating him pretty damn fast.
It was being decelerated.
Yeah.
But now we're going to sync the video, but I think that's good.
Another part of this study that I forgot to bring up is that they said the hamstring quad ratio was not related to the Y balance test. And that kind of makes sense. Due to quad weakness early on, it's probably not going to be that much related. But the point to make is that the hamstring quad ratio is very important in the female ACL patient. So what do you not want in a female ACL post-op patient? You don't want a quad dominant individual. And we've seen that before in some of our soccer players. You look at them and their quad look enormous. They look fantastic. But really what we would like to have is the hamstring, kind of come back. So they have a low hamstring quad ratio because their quads are so enormous. So if you see someone that has a dynamic, huge quad that's a female athlete, Ed Voigt has showed that may be a predictor of possibly having an ACL tear. So the hamstring quad ratio is something to look at. I mean, normal is 0.6. And someone that's a quad dominant individual, it might be 0.40 or whatever. So you want to look at that just for the female athlete.
Someone, James, on the question and answer asked, is there or he said he feels there's a difference between female and male landing in the amount of degrees of flexion in various planes. And I think that's been shown quite a bit in multiple studies, right? That women tend to not flex as much upon landing, flex their knee as much, and they're more quad dominant, I guess, on landing.
Yeah, that's one of the things that they teach in the sports metric routine is to teach them how to, you're making me dizzy.
Sorry, my
camera
keeps moving. Yeah.
Is to try to teach them to land in a little bit deeper knee flexion. The question is, can you make that overflow to reality? I think a lot of it has to do with two things. You've got to have the engine to drive the knee, which is your quad. And then you have to neuromuscularly teach them how to use it because they won't use it if they haven't been using it,
Yeah. Russ, one more test. I think we're past our time frame actually, but maybe one more question here. Someone asked about your Michael asked about your posterior hop test. Is there a certain distance normalized to body height with the backwards hop to consider to pass thresholds, or is it more, do you base it on the opposite extremity, or is it like a limb symmetry index? Or
yeah, for sure, it's a side to side difference.
Okay.
And we didn't really talk too much about that in the other paper, but well, we did a little bit. So it's kind of like using the peak torque to body weight ratio when someone has a contralateral graft in their ACL. You don't have anything to compare to. So this one you have to have a normal side to compare to, and then hopefully one day we can develop those numbers that are normal for height and weight. That's a good idea.
Yeah,
good point. Yeah.
Good question. All right, guys. Phil, you got anything in closing?
No, this is great. Thank you all very much. I appreciate it. And thanks, Ashley and Mike.
Yeah, Ashley and Mike, thanks for setting up. Mike, thanks for hanging around with us
Yeah,
today. This is the first time you've actually hung around the whole time, so we appreciate.
No, I'm
you,
actually in the
hanging out.
background sending notes to you all the time, trying to mess with you.
I got a few of them.
Yeah.
Thanks,
Thanks,
Phil.
guys. Appreciate the
Your expertise.
invite.
And
Thanks, Russ.
Russ, really appreciate you coming on with us, and we'll definitely get you on again in the future. We appreciate your help.
No problem.
Thanks everyone
guys.
for
Night.
participating, and be on the lookout for the certificates and reach out to me with any questions, and we'll see you next time.
Okay. Good night, guys. Thanks.
Thanks. Good
Good
night.
night.